Okay, so no moderator. This is just.
Let's go by. We'll say a few words each, and then we'll talk. How about that?
Sounds great.
Well, I love this topic. This is what I proposed to Stella that we talk about. So I run the Open Therapy Institute, and the whole mission of the organization is to catalog blind spots in mental health. Anything that we're not talking about, it's taboo or it's ignored, and it's impacting patients. So a lot of times when I say this, people are like what? What's the mental health field missing? A lot of times trans comes up, but I have a list here. So these are just the topics in our most recent journal, so you get a sense of it. One of them is self-censorship is becoming a mental health crisis. You don't know how many people seek therapy because they're isolated and they don't know how to speak up. Intensive parenting damages mental health. Over-involved parenting, giving kids anxiety disorders, things like that. The fear of being canceled. People who have social anxiety, generalized anxiety, OCD related to saying something that ruins their life. Recovery from transition, an article on therapy with detransitioners. Navigating political polarization in families and couples. This is a constant theme. Basically, almost every therapy these days centers around politics. About 10 years ago, 20 years ago, it didn't come up that often, and now it's like the large majority of therapies, politics comes up sometimes, and usually therapists sidestep the issue. They don't engage with it. They're uncomfortable, or they can kind of sit there and nod, but they don't have anything constructive to say. It's a perennial theme in therapy. We have biases against men in couples therapy, improving mental health care for police officers, anti-white racial aggression. Just a quick note on that. We did a lit search of how often that topic comes up in peer-reviewed journals, and we found that the phrases anti-white aggression in psychology journals came up 0 times. There's no articles on it. And so I think we have the first peer-reviewed article on the topic that's coming out. Therapy with minorities who have heterodox viewpoints, how therapists fail religious clients. I could go on. I do want to say that we are constantly looking for people to write articles for our journal. It's peer-reviewed. I want to give a list of topics we're actively seeking so that this will also kind of illustrate taboo topics and blind spots in the field. We want case studies and literature about treatment for people who've been canceled. Social and professional consequences, threats, and things like that. What do they experience? What treatment interventions are effective? We want articles on the value of group therapy for ideologically marginalized people. I think group therapy is critical for parents of trans kids or detransitioners or the other groups that you've heard about, but also for lots of other groups of people who are attacked for their beliefs or isolated one way or another. The psychology of political violence. Viewpoint and loneliness, isolation, and its clinical dimensions. Family members of people who transition, especially not just parents, but kids, spouses, siblings, grandparents. Gay men and lesbians who feel at odds with LGBT plus culture, one way or another. Queer theory in the clinic room. There are places that advocate for queering the therapeutic space, queering therapeutic processes. Inpatient transitions, people with psychotic disorders who go through transition. What secular therapists need to know about evidence-based mental health for people of faith. Pro-divorce bias among therapists. Abortion in therapy. Male issues that are neglected, failure to launch, irritability, aggression issues, just the variety of male-skewed problems that tend to be neglected. So I could go on. We have, clearly dozens and dozens of topics like this, and so if you're interested in writing on any of these, contact us. If you're a professional and you're interested in learning about these or building a practice around these, contact us, become a member. If you're a patient and you're looking for a therapist on any of these, contact us. Go ahead.
Okay, I will go next. Just first, I'm thrilled to be here. I was here with this conference 2 years ago, just in the audience, and it feels like it's been 2 lifetimes as opposed to 2 years, and I'm only in the trenches at the medical level. Like she said, I'm a board-certified psychiatrist and psychotherapist in private practice, but this has become my primary focus. When I heard about our topic, it's interesting. I thought, okay, what kind of taboo things can we talk about? And the way I look at it is anything other than affirming has become taboo in our world, which seems upside down and backwards, and so I'm just thrilled to be able to be here. I firmly believe that if medicine continues to believe that it can improve on the intricately complicated, phenomenal cascade of processes involved in human development, we are completely lost. We can't do better than healthy bodies, and this is the one area of, I'm going to call it pseudo-medicine because it's not medicine, but it's this area where we're altering healthy bodies to somehow better align with a child's underdeveloped sense of self in that moment. That's not medicine, that's criminal, that's abuse, and that's why I'm here. You know, I think the other thing that we think about is, that's why I love these conferences, because as I'm hearing all these brilliant speakers talk, and I'm jotting down, oh, I want to talk about that, and oh, I want to talk about this. Now we've got, hours and days and months and years I could spend with each and every one of you talking about all of these things and your experiences. First and foremost, because you guys do not hear it enough, parents and grandparents and caregivers and family members and those of you who've been through it yourself, you are enough. You've always been enough, and this is not your fault. This is the medicine that is being practiced right now. It's medicine's fault, it's mental health's fault, and we've got to make it better, and please know that we're fighting too. Okay, we're out there, we don't want to stop fighting. I've met more and more people, like the person on my left and right, that all want to fight this fight. You guys are in a place I can't even imagine. I have kids of my own. They didn't get caught up in this, but they certainly have friends that are caught up. We have family members that are caught up outside of our nuclear family, and I can't imagine, so please know we're going to fight the fight when it feels like you can't do it. Just being here is enough. I think the other thing that got brought up earlier, and I thought it was such a brilliant thing to remember, is that hopelessness is the enemy of growth and self-awareness, and I feel like something that we're not allowed to talk about is this gender-affirming model exploits hopelessness. It leads with being born in the wrong body. Bodies aren't wrong, our bodies aren't right, they're the bodies that we have, and we have to grow in those, but it concretizes and locks in a sense of self that is so narrow, and that, again, has become taboo to talk about. But affirming is not validating. My job is to validate feelings, whether they're positive or extremely difficult and negative, but that doesn't mean I let go of truth. And truth's subjective. It doesn't get to be one person's truth or someone else's truth. But again, it goes back to affirming isn't the same thing as validating. And I actually stole that from a talk that someone gave 2 years ago at Genspect. So it's not even my own, but I think we come together and we certainly can come up with many more ways of fighting this. There was also one other thing that came across, and I'll pass it over to Jared. There was a question about being afraid to be brave. And why that is. Why are we telling our kids, why are we telling vulnerable young people, you should be afraid of being brave? And I think what has happened is these quote-unquote gender-affirming experts, they've pathologized discomfort. And discomfort does not mean that you have a disorder. Discomfort tells your body and or your mind or emotions that you need to shift out of it. You need to grow. And that's what's healthy. So I think when we try and tell kids, you're afraid and you should be, it makes no sense. Puberty isn't something to be afraid of. It can be scary. I don't know. We could look at a show of hands of how many people want to go back and go through puberty again. I don't want to, but we can't. But all that to say is, I think, what has become taboo is health and wellness, and holding reality for our kids and for vulnerable young adults when reality is scary. And it can be, but that doesn't mean we can change it, or worse, promise them that we can change it, and we can't. I feel like, especially online, and that was such a brilliant talk that was right before us, and that was incredible. Kids are being celebrated for proclaiming fear, and then fear becomes that locked-in identity. And they can't let go of it because they are afraid that if they do let go of the fear, and they do let go of who they are in that moment, they're going to lose their entire self. And so we've got to figure out a way to untangle that. So with that, I'll pass it over to Jared.
Thanks, Lauren. So I guess, as someone mentioned, I'm an emergency medicine physician, and something I tend to rarely mention as well is that I also practice addiction medicine, was just recently approved to sit for my board certification for that, and alternative psychiatry as well, which is psychiatry involving substances that are not traditionally used by mainstream psychiatry. So I think this is a very interesting topic, because the very nature of my work is, in some extents, is taboo. Emergency medicine is not taboo, but we see a lot for sure, and see a lot of the fallout of mental illness in the acute setting. People might say, well, why as an emergency physician are you dealing with gender distressed or gender confused patients? And I may not be dealing with their gender distress, but I see them for their acute mental health issues, and the two are very clearly linked. And I think that's something that we fail to give credence to, because just saying that is clearly taboo. But my other interests in medicine are clearly taboo. And thinking back on Genspect, watching these videos from 2 years ago, it's really a shame that Dr. Wilfred Riley, who is clearly the expert on taboo, is not with us here this year. Taboo is really such a great topic because it transcends just the gender issue. Despite medicine being a scientific pursuit, there are unfortunately these sacred cows. And I learned very early on in my medical career that you don't question the dominant mantra. So I attended osteopathic medical school, doctor of osteopathic medicine. And for those of you outside the U.S., in the U.S., MDs and DOs have exactly the same scope of practice, attend the same residencies, work side by side, often don't know who's a DO or who's an MD. I don't know most of the degrees of my colleagues, and they don't know mine. But the difference lies in medical school. And in medical school, DOs learn osteopathic manipulation or body work, similar to what chiropractors do. Yet, only 3 to 5% of practicing osteopathic physicians utilize body work in their practice. And why is that? I think there's a number of reasons. One is that there's a very poor scientific basis behind it. So early in my medical school career, early in my first year of medical school, I proposed a rigorous scientific study to assess the interrelated reliability of these diagnoses of the spine, these diagnoses of spinal cord malrotations. And this was immediately shut down by the dean of the medical school. I was not allowed to pursue this scientific research. There were so many other topics I could have pursued, but this was, again, questioning the dominant mantra. And so this was shut down. And unfortunately in medicine, I think we see a lot of these taboo topics, whether it's discussing sex roles. There's no room for gray. Everything has to be black and white, right? We have to say that women can be CEOs and women can pursue whatever careers they want. But at the same time, we can't acknowledge that it's in the female nurture by and large, on a mean, on average, to be more geared towards social interactions, more geared towards raising children. I'm not saying that women should be kept out of the workforce or forced to be stay-at-home mothers. I'm not saying that men shouldn't be allowed to be stay-at-home fathers. But if we're just simply allowed to observe and acknowledge human nature and human biology, but we're not. That is taboo to talk about, taboo to recognize. We can have means and averages, and we can recognize that we're all individual humans, and we may defy stereotypes, and there's nothing wrong with that. That doesn't make those who defy those stereotypes lesser. It just makes them different, and that's fine. We thrive in a society with people that bring different strengths to the table. And so while I'm up here on my soapbox, I'm going to touch on another very controversial topic in medicine. And I hope this goes off okay. But when I first came into the gender space, which was actually another story, but in my junior year of high school, and why in my junior year of high school I was researching this is another question for my very ideological high school. But I had real questioning. I started examining disorders of sex differentiation, or what at the time was called intersex disorders. And as a Jew and as someone who knew I wanted to go into medicine and be a physician, I really had this quandary that we were speaking out against mutilating the genitals of children who were born with disorders of sex differentiation, with ambiguous genitalia. And we are now speaking out against mutilating the bodies of children who are experiencing gender distress and gender confusion. But yet, every day in this country and across the world, we're mutilating the genitals of infant boys. And I'm so warmed by that response. You know, I get called a Jewish anti-Semite for saying this. I've been called a transphobe as well. I mean, who hasn't, right? So I just add it to my honorary titles. But I think it's really important, and I'll be brief here and cut this off. But from an embryological perspective, the foreskin, the male foreskin, is identical to the hood of the clitoris. And removing the clitoral hood in a girl in the US is a felony that's punishable by 10 years in prison. And that's WHO, World Health Organization, Class 1A female genital mutilation. But removing the foreskin of a baby boy, the same embryological tissue, is a lucrative procedure that pays up to $3,000 a foreskin. And that doesn't account for the financial benefits to the hospital for selling these foreskins to biotech companies who make wound products and skin matrices to treat burns and wounds. And so I think what the takeaway here for me is that there's a lot of taboo topics in medicine, and especially, and anytime you contradict or question the dominant mantra, it's taboo. But especially when that compromises financial prospects for medicine, it becomes a very taboo issue. So I've gone on long enough. I'll turn it back over to these two.
Well, it seems to me like that the main issue across all of these is really that universities have pervasive biases in every discipline, and the gender ideology is just one feature of what are dozens and dozens of really deeply ingrained biases that need to be responded to.
And, to tie this back to our work at Do No Harm, the progressive ideology, this identity politics idea that pervades not just gender, but race as well, is just so harmful and so hard to speak out against, and unfortunately so deeply ingrained in our universities, in our medical schools, in our healthcare institutions. And it's incredibly harmful because, again, it reinforces this idea that everyone needs to comport to these means and these averages.
I was taught things in my training that you had to bring up race in every therapy, often in the first session. I got a PhD in clinical psych. I didn't have one lecture on religion. Nothing on men's issues or masculinity. So I think the blind spots are just so numerous and so glaring. My lesson from the gender debacle isn't strong enough of a word, but is that this is an indication of how severe the biases are just across the board.
And I think if I could add to that, when I decided to go into medicine and certainly go into psychiatry, I didn't want anything to do with politics. My guess is that was probably the case for both of you. Maybe I'm wrong, but I'm making assumptions. But we didn't, it wasn't supposed to be about politics. I didn't want anything. I didn't like politics. There weren't politics welcome in the space with the patient, because I'm there to treat whoever that person is in the moment for the problem or the difficulty they were struggling with. I didn't pick and choose based on someone's politics or beliefs, whether it was religious or spiritual or otherwise. You treat every single patient with respect. You treat them comprehensively, and you provide them the best possible care. And what that means is the care you're providing them is rooted in evidence-based research. It's rooted in the best available data that we have, and that data can change. And if it does change and we learn more, we apply that to patient care. We don't tell everyone the science is closed and we move on and this is just how it's done. That's not how medicine or science has ever worked. But I think that's where we see that infiltration of politics into medicine, and when it gets all tangled up, the results are gender ideology, the identity politics in medicine, and it just turns into an abandonment of patient safety, wellness, and well-being. And that's, again, it's not medicine. So that's what we've got to work back towards, I think. And I think there are different universities, different institutions trying to do better. And my hope is it couldn't happen fast enough, but that's why I'm sticking with it. I don't want to bail on medicine or mental health or psychology or developmental psychology. Those are all, we've got to get back to what we know about humanity and human biology. And so just wanted to add in that I think, that our education isn't rooted in politics. So I think that may be part of how we got blindsided by this.
Yeah, it's also, I don't know, I think the psychotherapy world is a little bit different, because I think when you're with your physician, it does kind of seem weird for politics to come up frequently. But in mental health, my experience is that politics are the issues that people get most dysregulated about. They have incredibly strong feelings about them. They're getting divorced over it. They're losing family members over it. And they're really central to their distress. And what ends up happening a lot of times, and maybe people have had this experience here, is when you have a political issue, you go into therapy looking for support. A lot of times the therapist is maybe happy to listen, but they're not really engaged. They haven't read about it. They don't have any frameworks to understand what's happening or how you're impacted. They don't have tools to help. So I think that in mental health, this is it's become central to a lot of treatments and a lot of what drives dysregulation and conflict for people. So I think might be different in the medical world.
And I'm going to elaborate on Andrew's point, which I think was wonderful about race. And I think that's such a huge problem that we're experiencing in medicine today, right? That we have to view race as this social issue, and we have to then completely disregard the biological issues of race and ethnicity and heritage. And that's really the problem, right? We have to we've seen guidelines change that we're now not taking into account someone's race when treating their blood pressure, even though different races and different ethnicities may have different renin and aldosterone sensitivities. But we have to take that into account as a social issue, that this is simply a societal construct. And it couldn't be further from the truth. It's a biological construct, but race doesn't impact who you are as a person, or how you should behave as an individual. We need to really move away from that. I think that's a great point you bring up. Do we have time to take questions? No.